Yeah, thank you, Dr. Chaz. Good afternoon, everyone. Good afternoon, everyone. I hope the energy is not taken by the previous forum. So we need the energy similarly in this forum for the AMREF forum. My name is Arita Mutayoba. I work at a capacity of Program Director for Disease Control and Prevention, and I'll be moderating this session for the next hour and so. In the session today, we are going to discuss about successful engagement of community structures in public health emergencies, the experiences through AMREF's work in collaboration with the Ministry of Health and PORAJ, together through the support of US CDC, Tanzania. And historically, we know that the Ministry of Health in Tanzania is implementing an electronic integrated disease surveillance and response system that is IDSR framework since 1997 in all of our regions as a requirement for the international health regulations that aims to improve the ability to manage public health emergencies and priority communicable and non-communicable diseases. AMREF Tanzania, through the support of the US CDC, collaborate with the Ministry of Health and the President's Office, PORAJ, to strengthen the surveillance system for early warning and rapid response of public health events of international concerns at the national and subnational levels. AMREF runs about 15 years experience in strengthening community-based surveillance, where it first pioneered the community-based disease surveillance pilot project in Mkuranga in 2009, whose lessons are really key and build up on what we are seeing today. From the pilot project, its lessons were taken up, and in 2015, through the CDC support, we were able to roll out the community-based surveillance intervention in Kilimanjaro and Arusha regions, where it paved a way for the event-based surveillance that we are currently implementing in over 15 regions in the country, and for the US CDC support in 18 regions overall. To date, through the US CDC support, AMREF is working with a network of over 1,400 community health workers to detect and report alerts immediately. And we are glad to say that we are working collaboratively with the Ministry of Health, where we've established the alert management desks in a number of regions, when the Ministry of Health rolled out the electronic EBS system. And to set the stage, I would like to welcome the first speaker who will set the stage. Before the panelists go forward, we have the Country Director for AMREF Tanzania, Dr. Florence Tem. With due respect, I would like to introduce her. She has assumed this role since 2016 and had made history for the AMREF Health Africa Tanzania, being the first Tanzanian country director in that position, and she had been the first country director to champion the formation of the first local body of AMREF Tanzania. She is not new to serve at this capacity as the country director. Her record starts back way in Ethiopia, where she served as a country director for that country. And later on, she was really willing to bring back her talents and skills to benefit our beautiful country. Dr. Tem has been a role model to many, with a humble beginning of her journey at AMREF as a project manager, head of programs, deputy country director, before she was appointed as a country director. She had served at the Ocean Road Hospital, as well as the Muhimbili National Hospital, before joining the public health space. And she holds a degree in medicine, master's in public health, and a number of leadership trainings. Dr. Florence, kindly welcome to the podium to address the audience.
Thank you very much, Dr. Rita, and hello everyone. I'm not sure it's afternoon or morning, but I'm so glad to be in front of you. Actually, it's my pleasure to congratulate also the Tanzania Health Summit organizers, to recognize the importance of partners and different players in the country. And for that sake, we as AMREF got the opportunity to stand here before you. So it's really our pleasure and it's an opportunity for us. And again, I also want to thank our funders, CDC and many others, who have enabled us to be among the pioneers in the global health security space. And as Rita said, we started doing this a couple of years back, much as it's becoming now a very prominent agenda. For AMREF since 2009, we had the opportunity to pilot a community-based surveillance in Mkuranga. And through that experience, by 2015, through CDC support, we're able to do more of community-based surveillance in the border regions, starting with Arusha and Kilimanjaro, and then went further to more, actually now I think 8 regions now. And we have our panelists who will tell us more about that. But I must say, of recent, we have launched our new strategy, which will run for the next 8 years, with a lot of revision, etc. And one of the main strategic platforms that we are going to address is around social determinants of health. And that's where the issues around global health security will fall into that. And we have a very specific objective that's going to address, it's about supporting readiness of health systems for early detection and rapid response in outbreaks or pandemics, so to speak. And we are also building on experience. And I'm very happy to say that through that experience, we've been able to train a number of community health workers, and we have one here as a representative, in doing event-based surveillances. And it's done also electronically. And of recent, I think you remember, on 16th March this year, there was an announcement through the media of unknown disease that has emerged in Kagera region. And by 23rd or 21st there, it was confirmed to be a Marburg disease. And the person who actually picked the first signs was the community health worker. And she's here, Vedastina. It was through the same community-based surveillance, the same event-based surveillance system, electronic, she was able to alert the rest of the system, and there was a rapid response. So as AMREF, through that process, we are expecting, and this is actually coming along with the primary health care. We know that with universal health coverage, we still have to make sure that our primary health care is really set. But with emerging outbreaks, if the primary health care is not resilient enough, even the universal health coverage will never be attained. And so we are aiming at strengthening more on the surveillance systems and also facilitating rapid response, and also continue to work with the One Health approach. We have been working with the One Health desk through the Prime Minister's office, PORAG, and the Minister of Health, and with, again, the support with the different partners, including Africa CDC, but also CDC in Tanzania. So we are really appreciative, and we see that this is a time that should be a common knowledge, not only within the health sector. It's a multi-sectoral issue. At the same time, our community awareness and knowledge has to be should be known across. So increasing awareness of our outbreaks and such of common conditions that need to be reported immediately is something that we embrace and think we need to continue. And also integrating in existing services. So in doing that, we're going to address through the main pillars of health security. That includes the leadership and governance, but also community engagement, and I've already mentioned surveillance and disease intelligence, and there's also essential health services and laboratory diagnostics. We have been working through those space for a couple of years with the different experiences, And that's why we have our panelists here. We'll be able to share some of the experiences. I understand that time is not enough. I'm not trying to look at the clock there. I don't know how many minutes I've used already. But I know we have a lot to hear from the presenters and also more to contribute. So again, it's an opportunity for us to make a reflection to the experiences that we've gone through. We've gone through Ebola, we've gone through Marburg, but there are other diseases that we also report on, including anthrax, Rift Valley fevers, all those outbreaks that we might not come to the surface, but we're at least around 80,000 alerts have been made through this system. So it's really a workable system and should not underestimate the power of community health workers. Thank you so much and looking forward.
Thank you so much, Dr. Temu. Very well set and very well aligned with the current AMREF strategy and the effort that the government is taking through strengthening primary health care to attain the universal health coverage that aligns very well with the theme of this summit. I would like to take this opportunity now to introduce the panelists. We have Emmanuel Mwakapasa, who is a nursing officer with a specialty in field epidemiology and critical care. His experience records over 14 years in technical and strategic leadership in health workforce capacity building and 6 years in surveillance and response to public health emergencies. Mr. Mwakapasa works with the Ministry of Health as the national level event-based coordinator, and he had made records in spearheading the establishment of the EBS system in Tanzania, including development of a number of guidelines, training materials, as well as electronic reporting system and rolling out of the EBS in over 60 districts in the country in 14 regions. His competencies lies in disease surveillance, outbreak response, infectious prevention, leadership, data management, and scientific communication. Together with him, we have Mr. Selemani Yondo on my left from the President's Office, P.O. Raj, who is the Environmental Health and Sanitation Coordinator and has over 10 years experiences working with public health. He serves as a Senior Surveillance Officer at P.O. Raj, and he has a massive experience with community health-based intervention related to surveillance and WASH. He had been very instrumental in the response to COVID-19 when we had the outbreak in the country. He had been sitting in a number of project coordination teams, including the one that was implemented by the Ministry of Health, P.O. Raj, and AMREF in partnership with UNICEF to safeguard the continuity of essential healthcare services. We also have our guru, Ms. Lusungu Ngailo, who works with AMREF, with a record of over 15 years experience in community-based interventions, and in particular for community-based surveillance, HIV laboratory, capacity strengthening, operational research, proposal development, and championing of the community-based surveillance program in Tanzania. Lusungu has worked with AMREF for a prolonged period of time in project implementation and pioneered establishment of the CBDS project in Tanzania at Mkuranga district, which had led to the EBS implementation also in Tanzania. Additionally, throughout her career, she has successfully applied her skills on capacity building to train laboratory workers across the country, technical ability, aided in development of various national guidelines, including EBS, community-based surveillance, and guidelines. Together with them, we have the community health worker, whom I'll take a pleasure to introduce her when her time to speak arrives. So we'll jump straight to hear from Mr. Mwakapasa from the Ministry of Health. Can you please share with us the key milestone that the country has made throughout its journey in the establishment of the event-based surveillance in Tanzania?
Thank you very much, Madam Moderator. Yeah, before talking about the milestone, to put you into context, let me say something about event-based surveillance. Event-based surveillance is a continuous monitoring, detection, interpretation of events or of alerts may pose risk to human health. And these alerts can come from diverse sectors, spanning from animal sector, environmental sector, human health sector, and other sectors. So event-based surveillance encompasses the idea of, One Health. So it's a new, actually it's a very good thing as a country that we have started. So event-based surveillance was started way back in 2016. Actually, this follows the recommendation of joint external evaluation, which actually recommended that we should strengthen event-based surveillance, because it was found that we are good in indicator-based surveillance, but in event-based surveillance. So the IDSR system had strengthened. So as a country, we decided now to embark on event-based surveillance. So in the process of embarking on event-based surveillance, we actually developed tools like guidelines. Now we have a guideline, event-based surveillance guideline, but also standard operating procedures, training materials, monitoring and evaluation framework as well. And on top of that, now we started rolling out it to regions, focusing more on the regions, on the border regions. And we actually, up to now, we have rolled out event-based surveillance to 14 regions in Tanzania. And we have trained also community health workers, more than 4,000 community health workers, and more than 2,000 healthcare workers. Also, we did advocacy to regional and district leaders on event-based surveillance. And also, we sensitized village leaders like village chairpersons and ward executive officers. So now the community where we have rolled out event-based surveillance, or where we have rolled out event-based surveillance, is now vigilant. As you can see, we have started getting actually alerts from those regions. And another milestone worth mentioning is we also developed electronic reporting platform. Previously, we were doing a paper-based, and now we developed electronic platform. And this electronic platform, actually, the community health worker use mobile phones in reporting of alerts. And actually, it has proven very good success because the reporting rate has increased. Now we are getting around 70 alerts per day, as compared to previously when we were using paper-based, we were getting only 17 alerts per day. And also the alerts that we are getting actually come in a real time. So this actually help us to do actually response in a real time as well. Another milestone worth mentioning is now we have started doing media scanning at the national level. We are doing media scanning on a daily basis. We use epidemic intelligence from open sources, a tool from WHO, and other tools as well. So we do media scanning, but also we have hotline. The hotline, which is functional 24/7. There are people who are actually receiving calls from the public, and through those calls, we also get alerts. So this is also something worth mentioning as a very good milestone that we have achieved. And another thing, we have established alert desks in the regions. Up to now, we have 6 functional alert desks, where now we have people in regions who are actually watching of all alerts emanating from their respective regions. And do verification and response to those alerts. Yes, so this actually is milestone worth mentioning. Thank you.
Thank you, Manuel. Very well elaborated the milestone, and I would really like to hear from Lusungu now. How does the Global Security Agenda project fit into the milestone that we've just heard from the previous speaker?
Okay, thank you, moderator. Good afternoon, listeners. AMREF, as the previous speakers have spoken, AMREF has been part and parcel of these milestones from the beginning to now. We have been there from the development of the collection tools, from the training materials, the guidelines, the rollout of the guidelines in those 8 regions. We started with the piloting in Kilimanjaro and Arusha. And from there, then, from the lesson that we learned, we scaled up in other regions that are borderline. But also, we have contributed in the management of public health events of international concern. As the previous speaker said, we have managed several public health events of international concern, such as anthrax in Ngorongoro, and others like MVD in Kagera. We have managed other outbreaks like cholera outbreaks in Dar es Salaam, and they were managed in a very short time. And also we have contributed in the strengthening the community structures. We have sensitized the community leaders by engaging the communities from the initial stages of the project, so that we have the ownership of the project at the community level. And this is what AMREF is being doing in wherever we are going. We start at the community level, strengthening the community structures, the community leaders, the community health workers, and it's like not one shoe fits all size. We go with the community culture. Like when we go to Ngorongoro, we start with the Laigwanans. We don't go to the local leaders, the village chairs. We start with the Laigwanans, and then we go to the local leaders at the community. And they are the ones who are spearheading the project at the community level. So we have done this together with the government from the scratch up to now. And all the 14 regions, from the 14 regions, AMREF has rolled out the event-based surveillance in 8 regions out of 14. And out of the 4,000 community health workers that the government has rolled, AMREF has trained 1,400 community health workers. In those alerts that we've managed for 2 years, we've managed 84,000 alerts. So AMREF has been part and parcel of the government in the spearheading the event-based surveillance in the country. Thank you.
Yeah, so before I move to the next panelist, probably could share with us best practices and lessons that you've gathered throughout the implementation in Tanzania.
Okay, talking about the best practices, the project itself, the system itself tells about early warning and rapid response. So all through the implementation, we've seen the improvement and the strengthening of the early warning from the regions that we are implementing. I can take an example of the region like Songwe. Songwe is bordering Zambia. We had cholera in Zambia, so we ensured that Songwe is very well prepared so that they cannot get the outbreak from the nearby country. That is one of the success that we see. Another success that we see is the uptake of the project at the regions. As I said, we are engaging the communities from the initial stages of the project. So we have examples like Ngorongoro, Kigoma, Buhigwe DC and Kibondo DC. The government there, the local government, the districts, the regions, and even the local governments, they have taken the projects because we are not paying the stipends to the community health workers, but we are sensitizing the regions and the districts, but also the health facilities to set aside some funds to support the community health workers. So in those districts like Ibuhigwe, Kibondo, and Ngorongoro, they now have plans to pay the community health workers when they are working with them. So also to me, it's a success. Yes.
Great, thank you. So I'll move to Selemani. From the PRAJ, I know you are the ones who are actually overseeing all the implementation at the primary healthcare level and community structures being part of them and community health workers. How do you find the engagement of community structures, including community health workers, contributing to bridging the gap between the informal health system and the formal health system with regard to the management of public health threats?
Thank you very much, Dr. for giving this opportunity. Actually, community health structures are very important in public health emergency management. And actually what we need is to ensure that our community systems are able first to detect timely these alerts and report to higher levels so that the response can be taken within the time. And the community healthcare workers have been doing this work very efficiently, as the evidence was provided from the beginning of this session that even the Marburg first incidence was reported through community healthcare workers. So this is, it's very important to have this system which is enabling us to detect these alerts and being reported so as can be confirmed. The second thing, I think the health system, community health system is assisting particularly in providing responses that are reflecting the needs which are found within the communities. Why? Because within the communities have different needs. And within the communities there are different disparities. So these disparities can be easily identified by community health care workers. So as this information will enable us to design the response intervention that addresses the needs of different people within the communities. So for the experience and the evidences we have, for example, in Ngorongoro, wherever you start, you want to design an intervention to address an emergency management within the community, you should consider the needs of the people within those communities. And this information is you can get from community healthcare workers. So this is what actually we see. Another thing which community health workers are supporting a lot, according to the experience we had in this program, is that during the implementation of preventive measures toward these health emergencies, the community health workers, they were able to go to the community, provide health education, influence some behavioral change to their people. And the people were very easy to accept what they have been told by the community health workers. Why? Because they trust them, because they belong to those communities. So that essence of them belonging to the community is what makes the community to have confidence with what they are told in terms of how the diseases are transmitted, what behavior they're supposed to adapt. And they did a huge work during the prevention of COVID-19 throughout the country. And actually, another thing I wanted to say is about now as a PRI, we think that the sustainability of these community structures is very important. And how can we achieve this? One, I think we need to harmonize the activities which are done by community healthcare workers. This will enable these community healthcare workers to have a certain package of activities that they have to do within the communities. And to ensure that the activities which are addressed by different programs to be harmonized so that they can be done by one community health worker, rather than different programs having different community health workers. The second is to ensure there is sustainable financing for community health workers. There within the community healthcare facilities like dispensary and health centers, to ensure that we have funds which we allocate for providing payment for community health workers. And already there is evidence, as my fellow speakers have said, there are facilities who are able to pay for this, for the work they are doing in the community. So I think this is another issue which we have to be done. And another issue, I think it is continuing supervision and the capacity building to update them with real what is happening in the world in terms of health emergencies, and also conducting some periodic orientation so as to strengthen their capacity so they can deliver their activities very well. Thank you.
Thank you, Selemani. Very, very well put. The linkage between the community and why is it important? Because we have localized solution for the particular community, and being able to tailor-make the solutions that we are going to address the particular challenges. I'll go back to Emmanuel, and I would like you to tell us what are the challenges that are still remaining or that you are still seeing as we are implementing the event-based surveillance system in the country.
Thank you. Actually, the challenges. First of all, you know, EBS, we want to roll it out to the whole country. But now we have rolled out to only 14 regions. So we still have a work to do. So the issue now is, you know, funds for rolling out the EBS to the whole country. We need to do that. It's very important. But also to integrate it with other existing surveillance systems. We have a system, electronic EBS system, but we would also want that system to be integrated with other systems, like surveillance system from animal health sector, environmental health sector, and other sectors. As I said previously, EBS encompasses the idea of One Health. So we want also to get all the alerts coming from different sectors. So we want to integrate the system. Also, you know, to have like a guideline which actually is stipulating the issue of One Health, you know, the issue of One Health. The EBS guideline, but focusing more on the One Health issues. So, so the challenge is like now the ministries, actually we're working on silos, you know. Animal health sector is doing their own surveillance, human sector doing our own surveillance. But mind you, we have zoonosis. So, you know, we would also want to know what is happening to the animal sector. Also, we would also want to know what is happening on the environmental sector. So we really need to integrate the system. Yeah, thank you.
Thank you, Emmanuel, for sharing the challenges, and probably I can also call them the opportunities that are lying ahead to continue strengthening the event-based surveillance in the country. And I'll pose the same question to Selemani, who is overseeing from the PORAD and monitoring all the implementation at the community level. What are the remaining challenges that need to be addressed?
Okay, thank you very much. I will not be very far from what Emmanuel have said, but one of the challenges is issue of harmonization. You know, we have different partners who are actually working with community health structures, community health workers. So what actually we want to harmonize these activities. So we have that challenge of harmonization. So every partner like have his or her own community health care worker. So that one becomes very difficult to integrate those activities. And another way is to ensure, I was talking about issue of financing. So we want like every partner who want to support the community health structures to ensure we are supporting through direct health facility financing. So everyone, if it is paying a different amount to different community health workers. So community health workers become community health workers of AMREF, of IPATH, of HPSS, of someone else. So that way, the sustainability become a problem. For us, we think we have to agree that we have a certain token which should be provided to a community health worker per month. And all other partners who want to finance for payment of community health workers should direct their funds through the facility, the catchment facility, which is there. And the payment will be done from there to the, and that payment should be uniform all over to the community healthcare workers who are found within the same council, with the same region and the same nation. I think these issues, if can be addressed, will prevent the idea of every partner having community health worker. Thank you.
Thank you. Back to Lusungu. And can you please tell us now, looking forward, through AMREF and other collaborators who you are working with, how do you see your continued engagement in collaborating with the government for prevention, preparedness, and response of public health threats?
Thank you, Dr. Rita. As we have seen that AMREF has just launched its strategy of 8 years, and one of the strategic pillars is the social determinants of health. So we are looking at the social determinants of health, and in all areas, all the prevention, detection, and reporting and response of all the public health events, but also any event that is happening. So AMREF is working on those areas, especially in the, our project is working in the detection area, but we also have the prevention, but also the response area. We are working in the programs that are dealing with the vaccination. So I see AMREF will continue to support the government in the prevention of the public health threats, but also in the responding of the public health threats using the community structures that we are capacitating at the community level. Thank you.
Thank you. Before we go back to Emmanuel, I would like us to hear the voices from the community, which is the first-hand experience, from Vedastina Shumbusho, a community health worker, who will provide us with a vast experience in implementation of event-based surveillance as a community health worker. She had been doing that role for the event-based surveillance for 2 years, and she resides in Bugabo Ward, Nyalima Village in Kagera, DC. And she's attached to the Kiamalange dispensary as a reporting site. Vedastina also had been trained through CDC support and had received training on EBS as well as electronic EBS on early detection and reporting of public health threats using the Ministry of Health guidelines. And during the EVD preparedness, she also received some updates. Vedastina heard about the report of a death of unknown cause that occurred on March 15th from a nearby village and took an effort to report it in the electronic event-based surveillance system the early morning of March 16th in 2023. The reported alert was later declared to be MVD outbreak, and we find that she played a crucial role in alerting the system and hence the response to the MVD outbreak. Vedastina, karibu. Na tunaomba utueleze uzoefu wako kufanya kazi kama mhudumu wa afya ngazi ya jamii katika kijiji chako cha Nyalima, lakini pia ni jinsi gani ambavyo ulishiriki moja kwa moja katika mlipuko wa ugonjwa wa Marburg katika mkoa wa Kagera. Karibu sana.
Asante. Kwa jina naitwa Vedastina Shumbusho Vediani, natokea kijiji cha Marange, kata Rubafu, tarafa Bugabo, mkoa wa Kagera, wilaya ya Bukoba DC. Ni mhudumu wa afya ngazi ya jamii katika kitongoji cha Nyakalima. Nalipotia katika kituo cha kutolea huduma cha Marange Dispensary. Ilikuwa Novemba 22, nilipata mafunzo kupitia AMREF, CDC pamoja na Wizara ya Afya jinsi ya kuripoti magonjwa ya mlipuko. Na niambiwa nikipata tetesi ya magonjwa ya mlipuko niitume ndani ya masaa 24 panapohusika iweze kuchukuliwa hatua na kufanyiwa kazi. Asante.
Na unaweza ukatueleza zaidi ni kitu gani kilikupa msukumo wa kutoa taarifa ya tetesi ya ugonjwa usiofahamika ambao ulitolea taarifa siku ya tarehe 16 mwezi wa 3 mwaka huu?
Ilikuwa tarehe 16/23 nilipata tetesi katika njia ya WhatsApp kwenye simu kwamba katika kijiji Maruku kata Kanyangereko kuna ugonjwa umetokea wa mlipuko usiojulikana chanzo. Kwa kuonekana nilifundishwa, nikapewa na simu kama kitendea kazi, nikabidi niitume hiyo tetesi panapohusika ili iweze kufanywa kazi. Na washauri wahudumu wa afya ngazi ya jamii wakisikia ugonjwa wa mlipuko umetokea, wasikae na hiyo tetesi, waitume haraka ndani ya masaa 24 iweze kuchukuliwa hatua na kufanywa kazi. Asante.
Na kama unaweza ukawaeleza washiriki ni kitu gani hasa kinachokupa msukumo kufanya kazi kama mhudumu wa afya ngazi ya jamii, na hususan kutoa taarifa hizo za tetesi ambazo kila wakati unatoa taarifa na zinakwenda Wizara ya Afya kwa ajili ya kufanyiwa kazi? Kitu gani kilichokusukuma ama kinachokusukuma?
Kwanza kabisa nafurahia kazi yangu. Kitu cha kwanza, jamii imenitambua na nawatambua na inaitambua jamii yangu. Kilichonisukuma nitume hiyo tetesi haraka, nilifundishwa mafunzo ya kutoa tetesi ya magonjwa ya mlipuko na nilipewa mafunzo hayo siku moja. Kwa hiyo niliposikia hiyo tetesi ya magonjwa ya mlipuko nikasukuma niitume panapohusika ili iweze kufanywa kazi. Nafurahia jamii yangu mpaka sasa hivi iko salama na nitaendelea kuilinda jamii yangu. Asanteni.
Asante sana Vedastina, na ni kweli unafurahia jamii kwa salama, utaendelea kuilinda. Na kutoka kwenye hiyo sentence yako ya kuendelea kuilinda jamii, kufanya iwe salama, I'll shift back to Emmanuel and kindly share with us all the recommendations or opinion looking forward to strengthen the event-based surveillance in the country. What are the recommendations, or what is your opinion?
Thank you, moderator. Yeah, actually, the recommendation here now is all about to increase the vigilance of the surveillance system. How Christina is a vivid example of a lot of community health workers whom we trained out there, what they are doing. So we want to roll out this community, EBS to all regions. But also, we recommend also, to engage the whole public, because now we have 199 number, the hotline, toll-free hotline number. We also would want this to be known to the general public, to make general public aware of what and how to report. And this is easy. We can just take posters, making community of what and how to report. So will increase the vigilance of the surveillance system. Is also more community health workers. Yes. Thank you.
Thank you. We still see that community health workers are vital, but also the general public is important, because for the example of Marburg outbreak, we remember the border rider was the one who is shunting patients, and they were dying along the way from the facilities. So it is important for everyone in the general public to get note of this toll-free number 199 and provide any alert that is available that is threatening to the health of human beings. Selemani, from the PRI perspective, we've heard the voice from the community, the experience from Vedastina. You've clearly highlighted the need for sustainability of financing the community health workers, but also harmonization of community health workers package. Do you see any other opportunity in addition to the two that we can strengthen to ensure that we have a responsive system with regard to the public health rates?
Okay, thank you very much. I think something which we can add among the two recommendations, it is to ensure community engagement and participation, and to increase more awareness to the community in terms of understanding about EBS, and understanding the role of community health workers. We know they know, but we need to strengthen more this, because when community takes ownership of this community health workers, is where now they can recognize them, because they have different forums. There are community health committees which are available there, so they have to recognize that community health workers are the one who are representing them in terms of notification of health events. So this is very important for the communities to take lead in this process, because this is community-based initiative. Yeah, thank you.
Thank you, panelists, all of you. And in summary, we've had the journey of the event-based surveillance in the country since time memorial of 15 years in 2009, when it was piloted in Mkuranga, and later on we had a support from CDC strengthening the surveillance system at community level up to today. And we've seen a number of milestones that we've taken. Guidelines are in place. We also have the electronic reporting system, but also a toll-free number that we can all access and report. And one of the success that we have through the electronic reporting is now we are seeing a number of alerts reported on daily basis have increased from 17 to 70 in a day, which is promising. Also, the Ministry of Health is conducting media scanning using the epidemic intelligence, working with the WHO. But also we have functional alert desks, though in few regions, but they are functional, and those are the priority regions. And there's a lot to be done ahead, looking forward on the sustainability for financing community health workers, also embracing the community structures, but also harmonizing the activities. I would like to open the floor for the participants. If you have questions or recommendation or any comment for further discussion, karibuni.
Thank you very much for this wonderful discussion, and it's glad even community health worker is among us, and this is giving the congratulations to AMREF. I've seen you have been a pioneer of community engagement and community health workers in Africa. Just by experience, we have seen that the practice of community health workers has been just program-based or disease-based. And now we have, it's the first time I'm hearing that we use them as in a surveillance. How best they can be integrated to have a joint that community workers are minimal package of areas which they see, or is it based that, for example, in surveillance, they perform surveillance and others focus on other things? And for EBS, just for highlighting, is it operating different from other channels like a few public health emergency operating centers, or does it go direct to prime ministers? Or also, how does it operate?
Asante sana. I would like also to congratulate AMREF for this initiative, but also for the panelists for a very informative information or presentation they've given. As the presentation were done, some questions were running into my mind and I would like to share so we can discuss. Regarding this digital platform for reporting or giving alerts, I would like to know how many false alerts are normally recorded, because when people get free kind of access to such kind of service, sometimes they abuse it. And if they are happening, how does the system or the system administrator control this kind of false alerts? Regarding the toll-free line, I believe you are referring to the AFIA call center. Would like to know as well how many calls are normally received apart from the other digital format in terms of reporting some emergencies. The other question goes to Suleiman regarding the linkages between the community health system and the formal health system. What happened in the area where there is no public health facilities? How is this community linked to the formal health system? But the other question now goes to AMREF and PORAG, as well as for the Minister of Health. You have this program that is running and it seems to be very promising. Have you done some kind of cost analysis to see what are the cost drives and how they could be adopted by the government? Because we have got many programs of using community health workers, but by end of the day, they are not being absorbed into the government system because of the different costs. Today in the morning, we were in a different forum. We were informed that different organizations compensate differently the community health workers, and that becomes very difficult to sustain these programs. So these are my questions. Asante sana.
Okay, thank you so much for presenters. I just wanted to ask a question for AMREF on, so we've been using community health workers, but it has been a challenge in terms of reporting, the reporting system of really identifying the value and the work that certain community health worker has been doing. So the reporting system, is there a way that we can have a system that is very unified or monitored even by the government system, in terms that these community health workers can easily report on what they have done, whether it's throughout the week or throughout the day, just to make sure that we are clear of the result, the performance-based achievement of whatever they're doing. So it has been a challenge. You're working with several community health workers, but if in a case you're asked, okay, what is the report, maybe a monthly report? I know we had there's a system that they have to be reporting, but it's not well placed. So maybe just to strategize and think through as partners and discuss how best can that work for us, because it has been a challenge working with them, reporting on what they've already been doing, maybe in a month or 3 months or 4 months. Thank you.
So I will let the panelists respond to this first set of questions, and then if time allows, we'll have another round of questions. We'll start with Mr. Mwakapasa, and then we'll go to Piora, then Lusungu.
Thank you. Thank you for the questions. Maybe to start with the integration of community health workers. Asked about if are they working in some program-based? The answer is no. Now currently, CWs whom we have trained, actually they are doing other programs, you know, like HIV, malaria, you know. So they are not solely for surveillance, no. And currently we are developing an integrated curriculum. As you have heard yesterday, the Honorable Minister for Health mentioned that actually we are in a plan of recruiting a lot of community workers. And the curriculum development is in a process. And that curriculum actually will have issues like maternal and child health, HIV, surveillance, and so forth, malaria. Just a minimal package for community health worker to understand, you know. So a community health worker will be an integrated person. He or she will do a lot, actually, surveillance issues, you know, malaria and so forth. And sure also sustainability. And how does CBS operates? Does the alerts actually do the alerts reported going straight to maybe to one health coordination desk of Prime Minister or EOC? Now the answer is, you know, as I said, we are now doing electronic EBS. So a CHW, once, you know, detected an alert, log into the system, and that information goes straight. Actually, it goes to all levels, from health facility, council, region, up to national level. But, you know, up to the Ministry of Health at the national level. It doesn't, actually, that information doesn't go to Prime Minister Office, no. But the EOC, you've mentioned a very good thing. Now the EOC, we are also in a plan of having, you know, regional EOCs, regional alerts, regional public health emergency centers. And within the EOC, there is a watch desk. So all those alerts are reported, emanated from the respective region, will be seen by the watch desk at that EOC, and also will be managed accordingly. Regarding the digital platform, how many false alerts and how are they controlled? In EBS, you know, we can say false alerts, but, you know, alerts is alert, or sometimes we call signals. Signal is verified information, and we encourage the public to report. We really encourage, let them report. Our task is to verify that information, only that. So we actually encourage them to report. We don't bother if that information is coming, is false or not. Our issue is to verify. So I can't really tell the number of false alerts or false signals. There are so many, because, you know, the system, EBS system, is more sensitive, and it should be so, more sensitive to capture a lot of alerts. Okay, and that is the one of the, you know, quality of this EBS system. It should be more sensitive. So the issue of you know, cost analysis, maybe my colleague also will help to respond on that. But EBS, we started EBS not just as a parallel survey system, no. EBS is within existing IDSR, Integrated Disease and Surveillance and Response System. So EBS is merged within the structure, existing structure of surveillance. There's no duplication of, effort or even, cost. So EBS is running smoothly within the existing structures. So we haven't done the cost analysis per se, but as I'm talking, we haven't seen any difficulty of implementing EBS because it is within the existing surveillance structure with no additional cost. I think I've answered my part. So thank you very much.
Yes, Emmanuel, only one question on the toll-free number. How many or other types of reports that are being received through that number apart from the health alerts, if you're aware of that?
The toll-free number is not only for, EBS or alerts, also toll-free number is all about, giving people, some people do ask some questions, need some clarity, they're reporting maybe, enemies management, regarding as far as healthcare is concerned. So it's, it gets a lot of information actually from the public, but we filter, we take ours, only signals or only alerts that now we take them and we work upon them. And other information is channeled to the appropriate section, maybe curative services. If somebody is complaining of care, then it goes to curative services. So we are getting some such information from the public.
Great, we'll move to Selemani.
Okay, thank you very much. I have some concerns from Al-Kebi about the linkages between this informal system, that is community health worker system within the community and the healthcare facilities, and particularly when it happened now within the particular community or in the certain village, there is no healthcare facility, specific public healthcare facility. What actually is done? One is, first of all, these community health workers, they have their mentors, their supervisors within their healthcare facility. We have one designated nurse or a health officer or a clinician within that facility who is the CHW coordinator. So the way the facility they operate in terms of catchment area. So the facility, even if the village have no facility, but it is a catchment area of a certain facility and a certain population. So every healthcare worker, all healthcare workers are attached to a particular, to their catchment healthcare facility. So they report to that one. I know there are some needs to be addressed because when now facility is a little bit far, there are some needs to be addressed for the community health workers to be able to report and also to be easily mentored because there are issues of transport challenges. But the arrangement of itself, the system, it is in terms that one health facility saves certain catchment area. So even those villages which have no facility, they are within the certain catchment area for the health facility, and there is a supervisor for community health care workers. And this issue actually of different organizations compensating differently community health care workers, I also mentioned as a challenge. And the way forward on this, we said that we need like to harmonize the rate actually we are supposed to disburse back to community health care workers. We agree on the certain rate, and that should be paid uniformly, and it should be paid through the facilities. And this can be ideally achieved through joint planning, joint annual planning within the facility. And in the facility planning, we have what we call cost centers for planning. And in every facility, we have cost center for community initiative. So it's where now you put all activities which are related with the community issues. So what actually it is important is to integrate the plans of partners and the government together if you are working to a particular facility, so as all the payment for healthcare workers should be channeled through the facility. So the issue here, I think now, maybe partners have their needs, the government have their needs. Now we harmonize their needs. And sometimes it's confidence. Now we are here to provide the confidence that our FAST system is working very well and it can be used to pay community healthcare workers. Thank you.
Great, the FAST system is working very well, I underscore, and it can be used to pay for the community health workers, as the experiences that we've heard from the lake zone regions, Mwanza and Simiu, where AMREF is using the DHFF system to pay community health workers, and it is working very well, with some improvement that have been made with the Ministry of Health and PORAJ after giving the feedback. Lusungu, please go ahead.
Thank you, Dr. Rita. I will respond on the how to get the reach from the community in a sustainable way. What AMREF is doing, we know the community health worker need a lot of engagement. So we came up with strategies to engage them more. So we have the WhatsApp groups, and in the WhatsApp groups, there are community health workers, but also there are healthcare workers, and we have the regional and district coordinators that we are working together, even the government coordinators, that we are working together to capacitate the community health workers. We mentor them, but we sensitize them on reporting of alerts that we get. So we have the electronic system, but we have not rolled out in all the country. So where we are using the paper-based system, we encourage the community health worker to report through the in the WhatsApp groups. And the system that we are using is the government system. So they are reporting just in the normal channel, the IDSR system in the health facilities. That's how we manage to get the data. Thank you.
Great, so we can get another set of questions, at least 2 people, then we can be closing the session.
Hi, thanks for this opportunity. My name is Happiness. Just wanted to ask one question. And first of all, I'd like to congratulate you for a good presentation and the good work that AMREF is doing. Mine is not specific for the emergency response, but looking at the CHWs as whole. And I think it is going to Selemani. I know we are speaking about UHC, and we know the role that CHWs are to play in taking forward this agenda. And as much as UHC is concerned, it means we are having this community that can freely access the services. But when we have this kind of very important people working at the grassroots, what initiative do we have to make sure that they are also covered and they are also protected, and they don't don't access services because they cannot afford it? So as we are looking forward to the packages, to having them integrated into the system, or even through as partners, is maybe how do we look forward to make sure that as we are engaging them, we also make sure that we are taking care of their health? Because when we cover them, when they can access the services, it is also easy for them to motivate the community, and the community learns through examples. So it will be easy for them as well to actually join or utilize our insurances and make sure that the community is covered as whole. The second one is just a follow-on from when you're speaking about the cost analysis of the community health services. I know most of the time we speak about how costful it is to kind of make sure one community health care worker is working, but maybe when we're looking at the costs, we should also be able to see we are comparing that cost to what, because we are comparing it to a life that is going to be lost. So as you're doing the cost analysis and finding it expensive, we should also think of the families that also can easily lose life because of missing a simple preventive measure. So that is my contribution. Thank you.
Thank you. Thank you very much for the presentation. But I would like to direct my question to AMREF. Now that AMREF is focusing on pilot regions and looking forward to engage, work with the community structures within the public in those regions through digital means. Now there is an opportunity through AFIA Core. How do you see yourself partnering or linking somehow so that you can cover the whole country, because the AFIA Core uses facilities, digital facilities countrywide. Now I want to know the position of AMREF to use the service provided by AFIA Core to facilitate their input to cover the whole country. Thank you.
Thank you. I'm Catherine Sanga. I just want to say that we appreciate the session, and we are delighted to see the Destina with us. And I would like to ask all of us to stand and appreciate the work she did to help us on this issue of Marburg. So before we end the session, I will appreciate if we can stand and thank her by giving her a clap of thanks. Thank you.
Thank you, we'll do that. She has another slot, and then we'll be able to really acknowledge her contribution. With her support, we are able to combat the outbreak within a very short time, and it had made history across our borders and across over the continents. So we have 2 questions. Selemani, you can start, and then we can have Lusungu.
Okay, thank you very much. Actually, I was not expecting this question to come, but it's a very helpful question. These community health workers, they are actually working, it is true, they are assisting a lot, particularly, for example, implementation of different disease control measures within the community. They are also assisting like in contact tracing during the outbreak. They are moving house to house to contact to trace the contacts of diseases. This means these people are exposed to different conditions, different diseases, and particularly even for those communicable diseases. So we need to understand that if they are working, their work is like they're exposed to a certain risk. So once they contact an illness, can they access healthcare services without any financial difficulties? That's a general question Happy was having a concern. And I think this one we have, as a government also and the partners, we have to think now particularly on this, and see when we are making some incentive package for the community healthcare worker, we should think also on covering him, because his or her work actually put him or her at risk of contacting different diseases. So for now, I just thank you, Happy, for this concern. So when we'll be developing the essential package for community health workers, then this is one of factor to be considered. Thank you.
Thank you. As we are transitioning to Lusungu, I would also like to get Dr. George Mgomela prepared for the closing remarks once we are done with the discussion. So Lusungu, please go ahead.
Thank you. He asked about the AFIA call. How can we maximize the use of the AFIA call center? Yes, we want now to make EBS viral by advertising every region. We plan to use the posters, radios, so that everyone can be aware of the event-based surveillance. Because the 199 number is also integrated in the electronic system. So it's not only about calling, it's also about messaging. and it's a USSD messaging, which is free, and also it can use even not a smartphone, even just a simple phone, someone can send a message. So we want to make it viral using the media channels so that everyone can be aware of the event-based surveillance, and they can use also the AFIA call center by calling. Thank you.
Thank you so much, dear panelists. As we're transitioning to the closing session, would like to at least get one remark from each one of you as a takeaway to all of us. And I will begin with the community health worker who had made every one of us in the country very proud that they are significant and their role is very core for health security in our country. Vedanstina, ninakukaribisha tena na una lolote la kutuambia ama una ombi lolote kwetu ama kwa serikali ili kufanya kazi yako iwe nzuri zaidi na uweze kuifurahia.
Asante sana. Mimi ombi langu, unajua hii ni kazi ya kujitolea, haina mshahara. Ningependa serikali au wadau wao wanatuchangia hela angalau ya vocha. Maana uweze kupata THS ukaituma bila MB. Asante.
Yes, it is very crucial, and it aligns very well with the comment from one of the delegates on the floor, taking care of the community health workers in totality, not only using them to provide information or going from house to house. With that, I would like all of us to stand and appreciate Vedastina on the good work that she did in March, and the country is very proud of her. Sasa tunasimama kukushukuru sana kwa kazi nzuri unayoifanya. Thank you, everyone. We'll start with Mr. Mwakapasa for the last word, takeaway, quickly, and then we'll have Selemani, Lusungu, and I'll be welcoming Dr. Mgomela on the podium.
Thank you very much, moderator. Actually, here I'm to appreciate actually the work that AMREF did with support from DC, and that's why we are here. We are seeing the fruits of surveillance. So I also call for other, support from other donors who actually will support now to roll out the EBS to strengthen the surveillance in the country. Strengthening surveillance in the country is also strengthening the global health, security, because now the disease do not know borders. So please, I welcome more support to roll out EBS to strengthen surveillance in the country. Thank you very much.
Thank you very much. Mine is to thank you all our partners actually who you are here, and one thing so as we can strengthen community structures and particularly the intervention within the community. In PRI actually when we are doing this council comprehensive plan, we invite stakeholders. So wherever you are working in a particular council, we want to advocate for the community structure strengthening. Please, when you get the invitation, because we invite everyone to come during the planning, we go and see the planning. I have said we have a cost center for community health initiative to ensure that now we really have some activities which are planned there to address the issues of community health care workers. So in doing this, because everything starts with planning, and during the implementation, that's an impact. If you have been planned well or good, then that will be seen there. So please, when we start in December planning, pre-planning activities for the next financial year, please let us cooperate together to make our Council Comprehensive Plan to be really comprehensive. Thank you.
Thank you. Integration, ensuring we have our plans integrated into the CCHP for a sustainable community health initiative or community health programming. Lusungu, karibu.
Thank you, Dr. Rita, and thank you all for listening. Mine is the appreciation. I appreciate the donors for support. CDC, they have been supporting us all the way, but also I appreciate the government. We have been working together as colleagues. They have an open door policy, which has allowed us to implement event-based surveillance in the country. And lastly, to all of us, let's take EBS as part and parcel of our lives, because when we detect early, we prevent a lot of problems. And we expect emerging and re-emerging public health events of international concern. So we must be vigilant. So all of us should be reporters, not only the community health workers. Thank you.
Thank you. So it's a role of each one of us to report the alerts for a public health security. With no further ado, I'd like to welcome Dr. George Mgomela, who is the Associate Director at the CDC Tanzania, to give us closing remarks, where the CDC Tanzania had been really pivotal in the strengthening of the surveillance system in the country since time memorial, and looking forward, that is still their passion. They are providing technical assistance as well as financial support. Welcome, Dr. Ari.
Yeah, you see? Okay. So it's Chaz Wanga doing his stuff. Thank you. I'd just like to appreciate all of you, but specifically to appreciate AMREF for organizing this forum, and appreciate our colleagues from the government of Tanzania. But just before I close that appreciation, I would like also to recognize my colleagues and friends from CDC. Wherever you are, please raise up your hands. Thank you. We prefer if we are referred as development partners instead of donors. You kind of remove us a bit when you call us that. I'd just like to thank you all, particularly the speakers, Emmanuel, particularly, coming all the way from Wimbury a long time ago. I'm very happy to see that you are leading this initiative at the moment. But I'd like all of us to think a little bit, what is global health security? Unfortunately, the term security there is slightly misplaced and makes us a bit uncomfortable to discuss that. But global health security is generally some of the activities which you can do proactively or reactively to ensure that certain public health emergencies are contained in a specific places, either geographic place or internationally. So what Vedastina did was truly helpful in that aspect, ensuring that information is passed on and eventually is supposed to be processed. So I'll still like all of us to give her another round of applause. Thank you. Tunashukuru sana Vedastina. Kama tunavyoelewa ugonjwa wa Marburg ni ugonjwa ambao unasambaa haraka sana. Juhudi zako binafsi zilisaidia sana kufika hapa tulipo. After that, I also like to appreciate our partner AMREF, whom we've been partnering with them from 2015, especially in this global health security, in ensuring that EBS, event-based surveillance, is rolled out in the country. We did in 8 regions, if I did not mistake. And I think we still need to continue this event-based surveillance. Is important. Kama mnavyoona kwa wale wenzangu ambao ni Kiswahili speakers, ubuyu ni mtaji. So any rumor is a capital. So please, all those rumors we have, we should not only pass them in WhatsApp groups, etc. There are formal numbers which have been passed here, and it's important for the government to know. But I'd like also to stress that this EBS system is very important, and it helped us in NVD. However, she reported timely, but there's a time lapse between the time she reported for the time when the index case was really defined to the public, leaving a lot of us maybe potentially at risk. So we need to do something there. And what I think needs to be done is actually digitalization of this system. So Emmanuel, again, I'm pushing this to you. We need this system to be digitalized. Of course, I understand there might be several layers of approvals, but it's important for us to have a digital system where people are able to report information processed, and eventually we launch response to it. Lastly, I'd just like to say that from the US government, particularly from CDC, we are committed to continue working with the government of Tanzania, Puralj, and our colleagues from MOH, together with AMREF and other stakeholders, to ensure that public health events are taken care of, global health security is prioritized, and overall programming in Tanzania. So thank you so much for listening to me. I'm so sorry I was in between you and your lunch. So now this session is officially closed, and you can go and have your healthy snacks. Thank you so much.
Tuwapongeze tena panel yetu led by Dr. Rita. Another round of applause. Pongezi nyingi kwa dada Vedastina kwa kuwa mstari wa mbele kutulinda wote, and we encourage that more. A couple of housekeeping. Make sure that you maintain your badge as we go for lunch. And lunch is served on the 3rd floor in Kilimanjaro. And with that, we thank you all for being so passionate with us, and we welcome you at 3 for the Girl Effect in Mikumi Hall. Asanteni sana, and